For those in attendance, good afternoon, or I should say good evening, maybe good morning to some of you. And it is an honor for me, courtesy of Geistlich, to have this opportunity to present to you my clinical experiences and my journey and evolution over the last couple of years using Geistlich Fibro-Gide for root coverage procedures on multiple adjacent gingival recession defects. Now, this is a significant problem in private practice, and in a busy periodontal practice like I have, this is something I'm seeing on a daily basis, and it's increasing year by year. And patients oftentimes come in with the complaints of aesthetic compromise, sensitivity of the exposed root surfaces, or fear of progression to the point where they might even lose a tooth. Of course, on top of that, as a clinician, I'm seeing more non-caries cervical lesions and root caries associated with these defects. Furthermore, oftentimes they're associated with minimally attached gingiva and thin zones or narrow zone of keratinized tissue, which furthermore lead to increased risk of development of periodontal disease and attachment loss. And so our two main therapeutic outcomes that we always strive for any root coverage procedure or treating recession is to obtain the maximum amount of root coverage, as well as to modify the phenotype from a thinner phenotype to a thicker phenotype, because we know that root coverage alone is not enough. We need to have a thick phenotype, gingival thickness and keratinized tissue width for long-term stability of the gingival margin. Now, unfortunately, the data for root coverage procedures for MAGR are rather limited. Most of the data that we have is derived from studies looking at localized gingival recessions, and that too, particularly in the upper anterior region. Having said this, the two most preferred surgical approaches for treating MAGR are coronally advanced flaps or a modification thereof, or a tunnel approach. And both of these approaches have been validated to be both successful and predictable in the literature. And we also know that with the addition of a connective tissue graft underneath these flap approaches, we significantly increase the probability of obtaining complete root coverage and marginal stability over time. We also know from the work of Professor Zucchelli done recently that tooth location also plays an important role in root coverage outcomes, in that maxillary MAGRs respond more favorably than mandibular MAGRs for root coverage and phenotype modification. And as well, interestingly enough, the distalmost tooth in any recession span seems to be the least favorable when it comes to root coverage and complete root coverage. Obviously, with a longer span of recession, we are going to have challenges with the harvest. We might be limited anatomically to harvest connective tissue, autogenous connective tissue of uniform thickness. And this can oftentimes lead to a negative postoperative experience for our patients. Also, we have to take the patient preferences in mind. Not all patients are willing. In fact, most patients, if given a choice, probably wouldn't want to take palatal tissue. Sometimes patients have medical considerations which preclude us from using autogenous tissue. And so this is where substitute materials like acellular dermal matrix and first-generation collagen matrices really have some value on our shelf. Now, let me make one thing clear. Autogenous tissue is still the gold standard and probably will be for some time. And although these substitutes are successful in the short term in terms of root coverage, in the longer term, I found that my results don't hold up as well. And as a periodontist, wouldn't it be just a dream to be able to have a substitute material that is equivalent in every way to autogenous tissue, such that we don't have to go to the palate anymore, or if we do, it'd be for very limited instances. The problem with the current materials is that they don't maintain their volume. And so I've been very hesitant and reluctant as a practitioner to recommend these in private practice. But all of that changed in 2018 when I was introduced to Geistlich Fibro-Gide in, I guess, late October 2018 at the American Academy of Perio meeting in Vancouver. And what was different about this particular device? It is a device because it's not a transplanted tissue. What's different about this device is that it has this unique property that no other material has of volume stability. So let me show you. You can take a dry matrix, and upon hydration with saline or distilled water, almost immediately there's a 25 to 30% volumetric increase in this material, such that if we were to squeeze this material and get all of the saline out, it would rebound back to the original size that it was when it was hydrated. So this is a pretty neat property, and it's because of the nature of the way that it's manufactured with the weak cross-linking that it allows for this volumetric stability. Now, this product was indicated for really treating buccal, contour, soft tissue deficiencies around dental implants, as Dr. Linkevicius and Dr. Levine have so elegantly shown in their presentations. It was also indicated for gingival recession, but in late 2018, when I was introduced to this material, there really wasn't any literature support looking at the use of Fibro-Gide for root coverage procedures. In fact, it wasn't until late 2019 and mid-2020 that the first couple of papers came out looking at Fibro-Gide in root coverage situations. The paper by Schulze, Spate, and Lee in 2019 looked at a VISTA approach with cut-up pieces of Fibro-Gide. They treated about 7 recessions, all fairly shallow, with reasonable success. And the most recent article by Stefanini and colleagues in mid-2020 looked at localized gingival recession defects affecting canines and premolars in 10 different patients using a coronally advanced flap approach with excellent success and predictability. So now I'm going to share with you a couple of cases that I've done from the early stages of my use of Fibro-Gide. And I've picked these 2 cases because they essentially highlight my thought process and my handling of the material. As I mentioned, when I started using this material, there's no literature guidance. So I was essentially flying blind and using my own experience and interpretation to help guide my use of this material and figure out what works in my hands. So the first case is a lady in her late 50s who presented with recession affecting her upper left lateral incisor, canine, and premolar. And we can see that the recession is actually quite moderate. And not only is there a recession, but there are also non-carious cervical lesions, particularly on tooth number 2-3. My guess is that the etiology for these recessions is from aggressive toothbrushing. This patient had a negative experience in her teenage years using autogenous tissue for free gingival graft and said to me at the outset, if this involves using my own gum tissue, then you can count me out. So at that point, I recommended right away to her, hey, why don't we try this new collagen matrix that I think could work really well in your situation. And she was very open to that. And just anecdotally, I think Dr. Linkevicius touched on this. I have more acceptance with xenograftic products for these indications than with allograft products because these are not transplanted tissue. They are actually medical devices and there's no risk of disease transmission. So this was one of my first cases, my first case of multiple adjacent gingival recession, but one of my first cases overall in early 2019. So we start off by making our incision design. And here I did essentially a hybrid between the conventional trapezoidal flap with a vertical releasing incision coming across the papillas, and then an oblique incision to avoid having a vertical in the aesthetic zone, a la Professor Zucchelli and colleagues with the surgically rotated papilla. I then raised the full thickness flap to the mucogingival junction, and then beyond the mucogingival junction, dissected split thickness to obtain maximum closure and release. On the left here, we can see our Fibro-Gide in its dry state. On the right, we can see it being hydrated in saline. Now, my rationale for hydrating this is because this, again, undergoes a 25 to 30% volumetric increase. So I want it at its maximal thickness before I put it into the site, because if it continues to expand after the patient goes home, I have a feeling that can lead to compromised healing. So we want to make sure we've gotten all the expansion out of the way first. I have made no attempt to trim this matrix in this particular case. I put the matrix to completely cover the exposed root surfaces, and it stayed there so well that I thought, do I need to actually suture this material in place? Because at this point, dry, it's 6 millimeters thick, and hydrated, it's probably 7 or 8 millimeters thick. And it stayed there so nicely that I thought maybe if I closed my flap over the material, that flap will provide sufficient pressure against the matrix to help hold it in place. So I persevered. After deepithelializing the interproximal papillas, I obtained tension-free primary closure. Now, I can tell you that this was more effort than I thought it would be. So keep in mind that your autogenous tissue and other matrices have maybe a millimeter, millimeter and a half to 2 millimeters thickness, and getting coronal advancement is relatively straightforward. But now when your material is 6 to 8 millimeters thick, all of a sudden this becomes almost like a GBR now, where you're really having to get good release. Nonetheless, we got good release here, and we covered and submerged the material completely. So let me take you through the healing sequence from 1 week to 2 years. I was very obsessive about calling this patient back for follow-ups, and we can see nice healing from 1 week to 4 weeks, and then 2 months we see good tissue maturation, but we can still see the delineation between the flap and the interproximal papilla, which over the next 3 to 4 months became virtually indistinguishable. And by 1 year, we have near complete root coverage, a little bit less on the first premolar tooth, but that's expected from the literature. But we've achieved a very nice result at 1 year for this patient, and she's happy because all of her chief complaints have been addressed. At 1.5 years, we can see sustained root coverage and nice, healthy tissue. So when you look at the preoperative, this is a substantial difference that we made for the patient. And the patient was very happy because she has no more sensitivity, aesthetic concerns have all been alleviated, and she was extremely happy because we did not have to go to the roof of her mouth. Let's focus in on the 1 week post-op for a minute or so. At 1 week, we see this dehiscence type of reaction. And I was thinking to myself, what could have caused this? And the only two things that I could think about were that maybe I should have sutured this matrix in place, or maybe the matrix was too thick for the overlying flap and left a little area where the blood supply was a bit compromised, leading to some partial necrosis here. So as we learned from our experience, I decided to do something different for my next case. This is a gentleman in his early 20s to mid 20s, biomedical engineer, healthy, non-smoker, wanted to have his recessions on the upper right quadrant addressed. The recessions are particularly pronounced at the canine and first molar, and milder for the first bicuspids. And I feel that the etiology for his recessions are more because of the prominence of his teeth. Once again, he did not want to have his own tissue from his palate used because he was in a very busy job, did not have the luxury of downtime. Being a biomedical engineer, I introduced the concept of this matrix to him, and he was kind of curious and agreed to let me use this. So once again, we design our flap with horizontal incisions across the papilla. This time I put my vertical release at the mesial aspect of tooth number 1-3 because I figured I want to get maximum release to completely ensure my chances of covering up that canine because it's in the aesthetic zone. Again, full thickness flap to the mucogingival junction before we do a split dissection. And you can see a nice picture here of the periosteum being retained on the bone. This time though, I took the Fibro-Gide and I reduced the thickness in half to 3 millimeters, and I created 2 pieces of Fibro-Gide. At 3 millimeters dry, it works out to about 4 millimeters hydrated. So after hydration, I placed the matrix in place, and this time I secured it around the necks of the teeth to completely cover up the recession defects and used chromic gut sutures before coronally advancing the flap in a tension-free manner. And I can tell you this time, with the reduced thickness of the material, the advancement was a lot easier. As you can see here, I've been able to coronally position the gingival margin almost 1.5 to 2 millimeters coronal to the CEJ, which, as we know from the work of Professor Pini Prado and colleagues, is actually a pretty important predictor of the final resting place of the gingival margins in the long term. Here's the healing sequence from 2 weeks to 1 year. And while I was very happy with my first case that I showed you, the healing in this case is so much more cleaner. And by 1 year, we have almost indistinguishable features of the papilla here. We've got complete root coverage on the canine and bicuspids and partial root coverage on the molar. And looking back in retrospect, perhaps I could have reduced the prominence of that molar root surface a little bit more. But nonetheless, I'm very happy with this result. And the frenum that you see associated with the 1-4 is not as significant as it looks. It's more of a photographic retraction effect more than anything else. At 1.5 years, we see healthy tissues, complete root coverage sustained at the canine and the premolars, and partial root coverage of the molar tooth, but we've increased the vestibular depth here and the amount of keratinized tissue. And we've also addressed the patient's chief concerns of aesthetics and sensitivity. So overall, I was very happy. And again, keep in mind that as an early adopter, these were some of my first cases without any guidance from the literature whatsoever. So some results that I want to share with you that I've obtained in private practice, which are not published, but I'm hoping to at some point in the near future, all deal with using Fibro-Gide for covering exposed root surfaces. I've chosen cases that had minimum consecutive cases with 18 months follow-up, representing 5 patients and 14 recession defects, mostly RT1 recession defects, mostly in the maxilla, and mostly in healthy patients. I figured I'd at least stack the odds in my favor so that I can get some positive results. Yes, I'm a victim of selection bias here, but nonetheless, I'm trying to show something. And the minimum initial recession depth I had is just over 3 millimeters. And what I've been able to show is that the mean root coverage, and again, it's only 5 patients with 14 defects, is between 85 and 90%, but 9 out of these 14 defects had complete root coverage. So I'm quite encouraged by this. Because again, these are early cases. There's still a lot we need to learn. So I look forward to seeing what happens in the next few years when we get more data. And certainly I'm hoping to publish this at some point as well. So some final thoughts and lessons learned. We know that multiple adjacent gingival recessions is a complex clinical scenario. And it's complicated by the fact that we have limitations with how much tissue we can harvest. And for some patients, this is not practical, feasible, or even desirable. Hope I've been able to impress upon you that the Fibro-Gide is representing a promising alternative or substitute to autogenous connective tissue. And it's unlike any of the other tissues that are available on the market or products on the market because it has this volume stability. Generally speaking, maxillary recessions tend to respond more favorably than mandibular recessions. In areas where we have at least a couple of millimeters of keratinized tissue already, the results seem to be better. And I'm convinced that around natural teeth for root coverage, we do need to reduce the thickness of this matrix. Of course, more studies are required in both short-term and long-term. And I'm looking forward to seeing what happens with this material in the future. Of course, you can follow me on social media. I'm quite active there. And you can email me if you have any questions or for any collaborative opportunities. And once again, thank you all for your time. I'm grateful for this opportunity from Geistlich. And now I look forward to taking your questions.
Thank you, Vinay. Excellent. As a non-periodontist, I will try to ask you some important questions. You see, one is, when I have seen this volume of the Fibro-Gide, and we have seen that in our study as well. Sometimes it's damn difficult to really cover the site then with the flap. Now, do you always do then an incision of the periosteum to mobilize the flap?
Yes, in accordance with the principles of flap closure following any perioplastics procedure, I will always do a split thickness dissection, at the very least apical to mucogingival junction for mobility.
Okay, that's what I thought. The other one is, in the first case, you have seen substantial defects in the root surfaces. How do you treat the root surfaces when you do these surgeries?
A lot of it depends on how shallow or how deep the defects are. So in this first case, it was relatively shallow. So besides gentle root planing to try and remove some of the prominences, really not much else. I have started doing some conditioning with Pref gel, but other than gentle root planing, really not much is required.
Okay, now you said the gold standard, of course, is still the connective tissue graft, and I also hear that from Tony Scully, and often. You see now, how are the selection criteria for you now, today? When do you go for the substitute material to eliminate the morbidity in the palate for the patient? When do you think, that's not yet the case? How are the criteria?
So speaking quite truthfully, I think in the maxilla, there's a lot of room for success. So most of the cases that I do with this material for multiple recessions tend to be in the maxilla, because in the maxilla, vestibular depth doesn't seem to be as much of an issue. Quality of tissue doesn't seem to be an issue. So your initial starting conditions are already quite good. I'm not quite there yet in the mandible, because as we know, the anterior mandible is a whole different beast, and especially the posterior mandible. So unless we're able to modify the material or our technique, which I'm working on in private, it's still mostly maxillary recessions that I'm sort of cherry picking, as we say in North America, for these type of cases.
Now I know from Tony's school, and he's often using then the tunnel technique, so he will not use a horizontal incision. Is this also technique you are doing as a tunnel versus coronally advanced flap? Now, what is your preference there?
For connective tissue grafting in certain situations, I will use a tunnel approach. For this particular material, I'm not sure we're quite there yet with the tunnel, just because of the nature of the material. Once it becomes hydrated, it becomes, as you know, it becomes more degradable. So I would still go with a conventional coronally advanced flap, because I can also get more release with a coronally advanced flap than with a tunnel.
Because you could not get it in, I guess. You see, it's too voluminous.
Yes.
Okay, Vinay, I think I loved also your last comment. Of course, we have to document more to see the long-term, let's say the mid to long-term experience. And then I think the future will show how far we can replace the parallel connective tissue grafts. And I think patients will, of course, be very pleased, because that's an important issue as well, to reduce the invasiveness for our patients. So thank you very much. Is George Starp still active in Toronto? Is he retired in Malta? Or where is he?
I think he spends his time between Malta and Toronto. He retired probably 5-6 years ago, but he's still active once in a while. He was one of my mentors as well.
Yeah, he's a great guy, very great. Now, is he still lecturing?
I don't think he's lecturing as much. I think he's more of the level of keynote speakers now. Yeah. But I think he's still active once in a while.
Can you send me his email address?
I will certainly do that.
Because you see, yesterday the discussion for the upcoming AO Congress in I think San Diego in next February, and then I was invited as a keynote speaker, and we were talking with the organizer, other speakers, and I said, yeah, think about George Starp. I don't know if he's still lecturing, but I would love to see him again. And of course, his lectures have always been fantastic. So
absolutely.
Superb English.
Yes.
Good.
Yes.
Okay, Vinay, thank you so much. And
thank you.
We appreciate your input, and best regards to Toronto.
Thank you so much, Dr. Boozer. Bye-bye.
Welcome.